More and more psychiatrists are showing an interest in the subject of tricyclic antidepressant blood plasma levels. Here today to discuss the significance of these plasma levels and some of the problems that are encountered in making the measurements are Dr. Paul M. Keene and Dr. Mark Lanoila. Dr. Keene is Director of Clinical Chemistry and Professor of Pathology at McMaster University in Hamilton, Ontario, Canada. Dr. Lanoila is head of the Clinical Psychopharmacology Laboratory at the Duke University Medical Center in Durham, North Carolina. We begin our discussion with Dr. Keene.
As we're going to talk about tricyclic antidepressants and measurements of plasma levels, it will probably be quite useful to define what in fact these compounds are, and also to say a little about the definition or the definitions of depressive illness.
Well, first of all, I think that until the 70s, really not enough attention was paid to the classification of the patients in the psychopharmacological studies. There are exceptions to this, but at least in this country, as the research diagnostic criteria for psychiatry have been defined rather unequivocally. After that point, we have a common reference as to what kinds of patients we are studying. And indeed, depression is a heterogeneous disorder. We have several different ways of classifying it, but we have the endogenously depressed patients. Even among them, we have the unipolar patients who only get depressed. We have the bipolar patients who get depressed and manic, who cycle. And then we have to go back to the old literature where the characteristics of the time course of an attack of depression were described, where actually it was shown that there is a spontaneous recovery rate which is rather high from severe depressions if one waits long enough. So indeed we are dealing with a clinically heterogeneous population. An additional problem is that we are probably within the clinically uniform groups of patients, we are dealing with biologically heterogeneous groups of depressed patients. I think that Dr. Silkraut's and Dr. Maas's studies concerning MHBG and the Swedish studies and the studies from Netherlands concerning cerebrospinal fluid 5-HIAA level distributions in the depressed population point out that among the severely depressed unipolar patients, we have a group of patients where we could say that the primary lesion is probably in the norepinephrine transmission systems, and we have patients where probably the primary reason can be characterized as being in the serotoninergic transmitter system. And then we have to match this lesion with the clinical profile or the pharmacological profile of the tricyclic antidepressant. Indeed, we are dealing with very complicated issues. About the tricyclic antidepressants, they are drugs which chemically are closely related to phenothiazines, which are used as antipsychotics, but they have both pharmacologically and clinically a very different action. They don't have antipsychotic activity at all. They may, at the very onset of therapy, have some sedative properties, but later on, even that potency tends to vanish. At the moment, we have on the market in the United States two types of tricyclic antidepressants. We have the tertiary amines, amitriptyline, doxepin, and imipramine. And we have the secondary amines, desipramine, nortriptyline, and protriptyline. There are some differences as to the pharmacological action of the tertiary and the secondary amines. Namely, the tertiary amines tend to be more active in blocking the reuptake of serotonin, and the secondary amines are more active in blocking the reuptake of norepinephrine. And the reuptake blockade naturally is one of the proposed mechanisms of action of these drugs. But there are other pharmacological differences as well, which are relevant as to the side effects of these drugs, which I think we should discuss. And then you asked about the classification of depression as the clinical part, where the pharmacology of these agents and their clinical usage kind of converge. Well, that is a rather difficult point, but if we take into account that we are discussing plasma level determinations of the tricyclics, it really is very important to pay attention to the diagnosis of what type of depression one is treating, because so far the efficacy of the tricyclics as related to their blood levels in particular has only been demonstrated for the endogenously depressed patients. So getting back to the classification, where are the plasma levels going to be useful? As I mentioned, the word endogenous depression, which some people think to be a little bit dirty word, because there is some controversy about that word. I think we got to define that rather carefully. They are typically the persons who have the low mood, loss of energy related to all kinds of depressions, but who in addition to that suffer from insomnia, particularly the early morning insomnia, who have the loss of appetite and loss of libido. Many of these patients are also suicidal. However, there is some data in the literature suggesting that the patients who, in addition to these symptoms, are delusional are not very likely to respond to the tricyclics. So the delusional depressives may be a separate group, even though I must say that there is again some controversy concerning this particular point. It is clear that other types of depression, such as so-called neurotic depression, which basically is milder in its symptoms than the endogenous depression, that patients with this disorder also respond to the tricyclics. And this is a very important point, because a majority of the patients who present themselves with symptoms of depression are not endogenously depressed patients. Then we still have the whole group of atypical depressives who often suffer from hypersomnia and who tend to gain weight when they are depressed, and large number of whom are rather anxious in addition to being depressed.
So, accepting that we've decided which group of patients one should be treated, then we should ask ourselves too, in which situations are the measurements of plasma tricyclic antidepressant levels indicated. And I suppose this is really quite similar to any other therapeutic agent, in that this can be important in defining compliance, in the regulation of dosage, and also in the suspected overdose situation. However, these compounds are present really in quite small concentrations or low concentrations in plasma, and therefore the methodology that's used in order to determine these plasma levels could really be quite important. I wonder if you've got any comments on, for instance, fluorescence.
Yes, well, That's definitely a very sensitive but very non-specific method, which I think at this state we should abandon from using it.
And of course, the original isotope derivatization procedure described by the Scandinavian workers is extremely elegant and specific, but of course is way beyond the scope of the average laboratory.
Yes, it's very tedious, very expensive. I don't think that the patients or third-party coverage could ever pay for that kind of methodology.
And this would also be true of what is probably the definitive procedure, which would be gas chromatography, mass fragmentography.
Yes, exactly, and there is even another definitive procedure emerging, which is coupling high-performance liquid chromatography with mass spectrometry. But both of those are really too expensive procedures for routine usage at this point of time. However, they got tremendous significance in research as research tools.
One sees a number of reports recently of the use of radioimmunoassay techniques for the measurement of these compounds, and one is of course aware of the tremendous sensitivity of radioimmunoassay, but I think one should also be aware of the fact that with this particular groups of compounds that there may be enormous problems as far as specificity is concerned.
So far, all the reports that I've seen in the literature are really marred with this particular problem, because they have had to use separate extraction so that they extract the secondary amine away from the tertiary amine and then try to measure those separately, because the antibodies have not been specific enough so far.
So I suppose really that one could say at the moment that the most generally acceptable method is probably gas chromatography using specific nitrogen detector.
Yes, no doubt about that. And right now, high-performance liquid chromatography is also coming.
Yeah.
But definitely there are more methods and more laboratories using the nitrogen-sensitive detector gas chromatography than high-performance liquid chromatography at this moment. The advantage of the high-performance liquid chromatography is that, to my understanding, it gives a little bit easier access to the hydroxy metabolites. And there is some recent data coming out from the group in Sweden and from Goodwin's group at NIMH, which suggests that the hydroxy metabolites may be important to be measured on top of the tricyclic compounds per se.
I think, however, that both of the techniques that we've just mentioned should be put into a laboratory context. In other words, they are not similar to performing a serum sodium estimation. And if one does the arithmetic, a technologist of mine performing one plasma tricyclic estimation in the same period of time could perform 200 sodium estimations. And therefore, I think even though these assays are becoming more commonly available, it should be pointed out that they are still extremely expensive and also remain very complex. And therefore, the physician looking at results from these assays should be extremely aware of the quality of the laboratory to which the samples that he's asked for the assays on have been sent. And one really is a little bit concerned about quality assurance if this particular type of assay becomes extremely readily available. I don't know what your comments would be on that.
I agree 100% on that. The quality control issue is not taken care of at this point. There are high-quality commercial labs and research labs, and there are low-quality commercial and research labs. And as long as there is not a general quality control scheme in the operation in this country for the labs, one has to be a little bit skeptical about the results. One way around that, if one can do it, is to send a few spiked samples in a blind way to the lab and see what kind of results one gets. And one can even spike a certain standard solution and keep it in one's own freezer, and every now and then melt a small portion of that and send it to the lab, because these are stable drugs. So the concentration in the standard should be about the same, and one should get about the same result back from the lab. That's almost the only thing that I can see that a physician can do at this point to check out the lab which is doing the assays. There are a few labs which cross-check their results on a regular basis, and naturally then one can inquire about such results and hopefully get them, and then see what kind of quality, what kind of error margins are we talking about. But generally in the assays, even in the best labs, we are talking about at least plus minus 10% error margins.
In other words, if we receive from a good laboratory a result of 150 nanograms per mil, we're really talking about values which lay somewhere between 135 and 165 nanograms per mil.
Exactly, and basically clinically that really doesn't make that much of a difference, so that is assuring.
Now let's assume we've now found the perfect reference laboratory, which isn't too expensive, and we decide to send clinical samples to this laboratory. There are some things that we have to avoid, aren't there, in terms of poor collection of samples and poor timing of the collection of samples. I wonder if you've got any comments on this.
Yes, first of all, if we talk a little bit from the pharmacokinetic point of view, there are two approaches which one can take, and one of the approaches at the moment only yields itself in routine use for nortriptyline, even though it's coming for imipramine as well. The basic data is merging, and that is the single dose kinetic measurement, i.e. one gives the patient a test dose of the drug and draws a blood sample 24 hours later, sends that into the laboratory, gets the result back, and then using rather simple pharmacokinetic calculations, one calculates the dose the patient is going to need to reach a steady state blood level which will be within the known therapeutic range for the drug. That is one approach. However, the routine approach at the moment really is to wait until the patient is likely to reach steady state kinetics and then measure the plasma level. Well, first of all, a very simple pharmacokinetic principle says that it takes about 5 half-lives of a drug to reach steady state kinetics. Once the steady state kinetics have supposedly been reached, then there is still problems with the timing of the sample. We should really time our sampling so that we would be operating in the post-absorption and post-distribution phase of the previous dose, which means that we should wait until 10 to 12 hours after the previous dose to draw our blood sample. Once the timing is correct, then there are still problems, and that is related to how we collect our sample. The safest thing to do from the point of view of correct results probably is to use venipuncture and collect the blood into clean glassware. Not to use the vacuum tubes, because there are problems with them. There is a substance which leaches from the stopper, and that will cause displacement of the tricyclics from the plasma, and so the drug will be taken up by red blood cells and other cellular components of the blood, and the plasma levels will be significantly lower than they are in reality. Once the sampling has been done correctly, then, as we stated already earlier, then we don't have that many problems with these drugs from the point of view that they are relatively stable, and so mailing them to a laboratory is not a problem.
Please turn to side 2 of this cassette for the second part of this program.
When we receive back our assay result, there are certain things of which I think we should be extremely aware. And the first is that there is tremendous inter-individual variation in plasma levels achieved. In fact, I've seen figures quoted of up to 36 times for amitriptyline. And also you mentioned that it usually takes 5 half-lives of the drug to achieve the steady state. This again is extremely variable from individual to individual, isn't it?
Yes, I was trying to err to the conservative side when I was saying 2 to 3 weeks, because then I was taking into account that variability, because the steady state levels and the reaching of steady state, they are both related to the half-life of the drug, which again is related to the clearance of the drug from the body, which is really the meaningful term that the clinical pharmacologist would like to use. However, I think that the half-life concept is useful for the clinician, for example, from the point of view of deciding when to take a blood sample. The thing you mentioned about the variability of the levels is very interesting, and indeed up to 40-fold differences in the plasma levels in patients who look the same, who have very much the same body build, who are of the same sex and same age, have been observed after the same dose of the same drug. And as people have looked into this very carefully, they've demonstrated that probably about 10-fold variation is due to genetic factors, i.e. this is something which is inherited and genetically determined to a large degree. But on top of that, we have then the environmental factors, such as drugs which induce the metabolism and of the tricyclics, and drugs which inhibit the metabolism of the tricyclics. And I think in this context we have also take into account as drugs cigarette smoking or smoking in general, drinking, maybe certain oral contraceptives, certain combination preparations in particular, and in the farmers also the pesticides, which are absorbed through the skin and which can induce liver enzymes, and environmental pollution in general, whether that is industrial or from some other sources, will certainly affect the metabolism of these drugs. But what I want to get across is that the genetic factors are the largest source of this variation, inter-individually. But then we have the environmental factors operating intra-individually.
So that a single plasma level then represents really some of a whole series of processes of absorption, excretion and metabolism. And it's really a point in flux which can in fact be quite variable.
Sure.
I suppose another major problem is that if we use parent compounds, and by parent compounds I would now refer to amitriptyline or imipramine as classic parent compounds, that these are in fact metabolized in vivo, and that the metabolites may well be present in similar concentrations in plasma to the parent compound. We know that nortriptyline, for instance, has pharmacological activity. It therefore becomes important to decide whether we should measure the parent compound, the metabolites, a further metabolite, all three together, in order to decide on clinical efficacy. This, again, will present problems with the radioimmunoassay procedure, which, unless one goes through careful pre-preparation of the sample, these procedures are not capable of distinguishing the parent compound and the metabolite. What about drug interactions now? I suppose this is extremely important, that many of the clinical studies that trying to correlate plasma levels of tricyclic antidepressants to clinical effect have been bedeviled by the fact that the patients have been on other drugs at the same time. For instance, it's well known that giving phenobarbital at the same time as the tricyclic, in fact, will decrease the half-life and decrease the plasma level. So that, again, in trying to analyze the results of plasma levels, one should be acutely aware of drug interactions. The other process, which may or may not be important, I'd be interested in your views on this, is whether in fact variations in the plasma binding of these drugs can affect the rate of metabolism and therefore the rate of clinical efficacy.
Well, let me get back to the drug interactions question first. I think there are two types of interactions which are important. They really don't affect very much the interpretation of the given tricyclic plasma level as such, i.e. whether the patient is within therapeutic range or not. However, they will have a lot to do with why a patient is not or is within the therapeutic plasma level. As you mentioned, barbiturates can indeed induce the metabolism of the tricyclics. So if the patient is receiving concomitantly barbiturates and the tricyclics, one would expect a lower tricyclic level. The opposite is true for phenothiazines. Our neuroleptics do indeed inhibit the metabolism of the tricyclics, and when a patient is receiving concomitantly a neuroleptic and a tricyclic, one could expect a higher level of a tricyclic after a given dose. The same is true for certain stimulant drugs, which are occasionally used by psychiatrists in combination with the tricyclics. Methylphenidate, in particular, is known to inhibit the metabolism of the tricyclics, and so one would expect to see a higher level. What was the other part that you were asking?
The other question concerned protein binding of these drugs in plasma.
Oh yes.
How important may it be?
Well, it is an important factor, even though it has not been totally worked out yet how important it is. They are bound to several protein components in plasma. Particularly intriguing is their binding to acid alpha-glycoprotein, which represents about 30% of the bound tricyclics. The same drug also, the same protein also binds drugs such as the phenothiazines and propranolol. This protein, as we know, is an acute phase reactant. So when the patient has, for example, an inflammatory disease, then the concentration of the protein goes up and the binding of the tricyclic becomes more avid, or at least a larger proportion of the total plasma level of the tricyclic gets bound. The significance of this has not really been worked out. I have tried to get around this factor by measuring red blood cell levels of the drugs, but I'm not making any conclusive claims at this point that that would be a means which would get us totally by these problems. Theoretically, it has some advantages to the measurement of the total plasma level. Ideally, we would be measuring the free plasma concentration, but as both of us know, the difficulties as to the methodology are really formidable. We run into problems with the sensitivity of our methods because the free fraction is about an order of magnitude lower than the total concentration. And we also run into problems of how to derive our free concentration, because there are problems with both ultrafiltration and equilibrium dialysis. And there are also problems with the ultracentrifugation method, on top of the fact that all of these methods are rather tedious. And if we combine them with our drug measurement per se, we are talking about extremely expensive assays at the moment. But it is certainly something that we will be looking into in the future, and I would predict that as methodologies develop, we may be in few years measuring the free fractions.
We're also looking at the plasma binding problem and looking at measurements of the compounds and their metabolites in red cells. And one thing that's becoming fairly clear to us, in fact, is that the distribution between plasma and red cells, in fact, does not seem to be influenced by the degree of protein binding. But this, of course, is not to say that the distribution between plasma and receptors would not be influenced by the degree of protein binding. If we now try to look at the correlation of plasma levels of tricyclic antidepressants to clinical data, I think you'll agree that we enter a field which is extremely bewildering. But I wonder if I could throw some numbers at you and you can either accept them or shoot them down. Again, dealing primarily with tricyclics which are currently in use in the United States. Would it be fair to say that an upper therapeutic level for amitriptyline and nortriptyline combined, or imipramine and desipramine combined, might be round about 250 nanograms per mil?
I would say that we have not really defined any upper level for them, because there we're probably dealing with a sigmoid response curve, and at some point it begins to level off maybe. But to my knowledge, we don't have studies which would suggest that there is a clear downturn in the response curve, as has been suggested for nortriptyline. There are some investigators who have a few patients who have not responded to levels of the order of 250 nanograms per ml of these compounds, who have given them higher doses, and after reaching somewhat higher levels, the patients have responded. This may have to do with the type of depression that I think we ought to discuss a little bit later on.
Now, if we speak of nortriptyline and protriptyline, here the situation would appear to be a little different, in that a therapeutic window has been defined by some workers, and it's been suggested that the therapeutic range for these particular compounds sits between 50 and 170 nanograms per mil, give or take 10 or 15 on either side. In other words, below a certain level, poor clinical efficacy is seen, and above a certain level, poor clinical efficacy is seen. Now, again, the literature in this field tends to be confusing, but I'd be interested to know what your particular feelings are about it.
I think you summarized it very nicely, because the majority of the literature suggests exactly what you said. I think that there are problems in most of the reports which have not been able to replicate the windows which you pointed out, i.e. between 50 and 150, 170 nanograms per ml. And at least in a couple of the reports that I've been looking into carefully, which contradicted these window effects, the investigators did not wait long enough for their patients to reach steady-state kinetics of the drug. The other problem with some of the reports was that they excluded the severely depressed patients, i.e. the patients which the other investigators probably called endogenously depressed patients. And therefore, I think it was impossible to reach the same conclusions, because, first of all, different populations were studied, and on top of that, pharmacokinetics were not adequately observed, particularly in those studies which were unable to replicate these window effects. I think that that points out the extreme importance of diagnostic criteria, and also it points out that the clinician using the plasma level determinations needs some basic knowledge of pharmacokinetics. In summary, from the point of view of a practicing psychiatrist, it is important to realize that, first of all, the concept of therapeutic plasma levels of the tricyclic antidepressants at the present time is only applicable to severely depressed patients. The patients who meet the research diagnostic criteria for a primary affective disorder of the depressed type, or for so-called endogenous depression, as it's more often called in Europe. It may be that over and beyond the clinical division of these patients into unipolar and bipolar groups, there are biologically different groups within the group of unipolar depressed patients. However, at this moment, the biochemical measurements needed to characterize these separate groups are investigational and not practical or available for clinical practice. In the correct patients, one should use the plasma level measurements if the patient does not respond to therapy with relatively high doses of the tricyclics, to find out whether this patient happens to be a very rapid metabolizer of the drugs, or indeed a very slow metabolizer of the drugs, which particularly in the case of nortriptyline and protriptyline may be significant, since the slow metabolizers tend to build too high concentrations of these agents in their bodies. Also, when unexpected side effects appear in using the tricyclics, it would be prudent to measure the plasma levels. This may be particularly important if one is using a combination of the tricyclics with phenothiazine drugs or with barbiturate sedatives, which, by the way, should be avoided in patients on tricyclics. Once the decision to make a plasma tricyclic level determination is made, one should be certain that the samples are drawn the correct way, that the timing of drawing the samples is correct, and that one is using a high-class laboratory to measure the level. After that, I would feel more comfortable if the laboratory would indeed, as a part of its service, provide some consultation of what a given number means, i.e. to put the number into perspective as of the performance of the lab, what are the error margins of a determination, and also would give some kind of background from the present literature concerning the levels, so that the clinician could judge as to where his patient most probably is.
You have just heard Dr. Paul Keene and Dr. Mark Lanoila, participants in Studies in Psychiatry number 13, an audio cassette series presented to psychiatrists by Pfizer Laboratories. We at Pfizer Laboratories, division of Pfizer Incorporated, manufacturers of Cinequan, doxepin hydrochloride, have been happy to bring you this audio cassette program. The opinions expressed in this program are those of the physicians involved and do not necessarily reflect those of Pfizer Laboratories. Cinequan, doxepin hydrochloride, is a tricyclic antidepressant available in 10 milligram, 25 milligram, 50 milligram, 75 milligram, 100 milligram, and 150 milligram capsules, and in 10 milligrams per milliliter oral concentrate form. Sinequan is contraindicated in individuals who have shown hypersensitivity to the drug, and in patients with glaucoma or a tendency to urinary retention. The once-a-day dosage regimen of Sinequan in patients with intercurrent illness or patients taking other medications should be carefully adjusted. This is especially important in patients receiving other medications with anticholinergic effects. The use of Sinequan on a once-a-day regimen in geriatric patients should be adjusted carefully based on the patient's condition. Since there is no experience in pregnant women who have received this drug, safety in pregnancy has not been established. The use of Sinequan in children under 12 years of age is not recommended. Serious side effects and even death have been reported following the concomitant use of certain drugs with MAO inhibitors. Therefore, MAO inhibitors should be discontinued at least 2 weeks prior to the cautious initiation of therapy with Sinequan. Since drowsiness may occur with the use of this drug, patients should be warned of this possibility and cautioned against driving a car or operating dangerous machinery while taking the drug. It should be borne in mind that alcohol ingestion may increase the danger inherent in any intentional or unintentional Sinequan overdosage. This is especially important in patients who may use alcohol excessively. Since suicide is an inherent risk in any depressed patient, patients should be closely supervised during the early course of therapy. Prescription should be written for the smallest feasible amount. The following adverse reactions have been reported and should be considered when prescribing tricyclics, including Sinequan: dry mouth, blurred vision, drowsiness, urinary retention, constipation, skin rash, dizziness, nausea and vomiting, and raised or lowered libido. With respect to the cardiovascular system, hypotension and tachycardia have been reported occasionally. The usual starting dose is 75 milligrams per day. The usual optimum maintenance dosage range is 75 milligrams per day to 150 milligrams per day, with a maximum of 300 milligrams per day. As an alternative regimen, the total daily maintenance dosage up to 150 milligrams may be given on a once-a-day schedule without loss of effectiveness. This dose may be given at bedtime. The 150 milligram capsule strength is intended for maintenance therapy only and is not recommended for initiation of treatment. Full prescribing information for Sinequan, doxepin hydrochloride, accompanies this cassette recording.